Who's conducting the program? Am I audible? I think there's some technical issues. Ransing.
Can I be heard now, sir? Sir, can you hear me?
Yeah.
Sorry, sir. We had a small glitch here. So welcome to the Quadrilateral Summit. I will proceed with the house rules after our director's address. At this point of time, it's a privilege and an honor to introduce to you Dr. Ashok Puranik, who the Executive Director at AIIMS Guwahati. He is also retired from the armed forces and internationally renowned trauma surgeon. And he is now heading and spearheading this institution, which is going to dynamically alter care for 44 million people in the northeast of India. At this point of time, sir, I just invite you for your words, for your encouraging support. Thank you so much, sir. Over to you, sir, for your words of wisdom, sir.
Good evening, friends. I welcome you all to this quadrilateral meet related to the perinatal psychiatric and mental illness people go through. It's my proud privilege and honor to be among you to address this gathering. I hope it is going to bring out some good solutions related to perinatal mental illness. This is aptly required into this time because we are in a northeast where the perinatal maternal mortality rate is much more, and it appears there must be a lot of association. It does matter that what's your mental health before the pregnancy, during the pregnancy, and during the perinatal period, just after the parturition. So not many people suffer from this illness, which gets hidden, which is masked, maybe anxiety, maybe psychosis, or PTSD, so many things which remain elusive during the course of pregnancy. So it's a need of the hour to address this issue, and you are the expert in this field. I welcome all the people who are doyens in this particular specialty to contribute to the research and come out with the real solutions of this particular problem. And I hand over and the further proceedings to you all. And I congratulate the organizers, and I wish well for your success in organizing for the purpose it has been organized. Thank you very much.
Thank you very much, sir.
Thank you very much, sir. Thank you for your encouraging support all through. At this point of time, I would like to invite our Dean of Research, Dr. Rumoni Deka. She's a professor in anatomy, and she has been a bulwark of support for all of us as we are looking to expand perinatal mental health care, perinatal care across low and middle income countries. I would just request you, ma'am, to share your words.
Thank you, Dr. Sharad, first of all, for including me in this quadrilateral meet. I'm very thankful to the organizers. As we all know, and as Sir has rightly said, that the perinatal period, which extends for about 1 year during pregnancy and beyond, that is after birth of the child, is a very important period in a woman's life, in a couple's life, and more so in a woman's life, because a lot of things change in the woman's life, mentally, physically, her coping with her own life, her family, everything. So during this period, it is essential that mentally she is at peace and she is in the most sound mental health. And a lot of research has never been done earlier, but now as we go ahead, we see that so many of the mothers would be, and they already who have already become mothers, they suffer from these mental anxiety, then depression, and all these sort of issues. So to maintain and to improve their mental health, the initiative which has been taken by this Department of Psychiatry in AIIMS Guwahati is really commendable. AIIMS Guwahati has collaborated with a number of institutions as well as certain research facilities so that we can increase the number of research which goes into this field. And then actually a lot of study needs to be done as to this aspect of life. I congratulate you all once again for taking this initiative to bring forward and move forward in the field of mental health of women, so as to bring the awareness that studies and important steps need to be taken so as to improve the mental health of the mothers to be and the perinatal period mainly. Thank you so much, Sharad.
Thank you so much, ma'am. Thank you so much for your words, for your support, for all of the encouragement that you have given us. So going over to the further proceedings of the program, I would just like to inform all the people present here, just to reiterate, we have organized it in 2 different sections. The first section is going to be where we're going to hear from experts in perinatal mental health and perinatal health from different countries. So we'll be starting off with Thailand, going over to Tunisia, then to Indonesia and India. In this regard, we will also then follow it up with a discussion between disciplines, the relevant disciplines which are involved in women's mental health, which are involved in trying to improve perinatal outcomes in any country. And that's from the obstetrics and gynecology department. We'll have experts from the community and family medicine department, and as well as pediatrics. So without taking more time, I would like to introduce to you our next speaker, as Dr. Chonakant Chawla. He is an associate professor in psychiatry from the Prince of Songkhla University in Thailand. And she has been a DSP India fellow researching on perinatal mental health in India as well. I'm going to invite her to speak on perinatal mental health and mental health care services in Thailand. Over to you, Dr. Chonakant.
Good afternoon, everybody. And you can see, will I check? You can see my PowerPoint.
Yes, your screen is visible.
Yes, okay. My name is Chonakant Chawla. I'm the associate professor of psychiatry, and also you are research fellow from the DST at All India Institute of Medical Science, Guwahati, India. And what is the outline I would like to talk today? It's just 4 points. What is the perinatal mental health? Well, brief. and why the perinatal care on perinatal mental health is so important. And the third is about what is common perinatal mental health problems in Thailand and the service and challenges in Thailand now. In the right-hand side, you can see the picture. It's a very ancient picture at the Royal Buddha in the palace, in current palace in Bangkok. It's a Sita. We call Sida or Sita in your country. She, in this picture, she giving birth and she needs for goddess to help her. So that's what I would like to say is about perinatal women may get help, and it is very important for us, not for the multidisciplinary to help her or to help them. So in brief, we know that now is it extend perinatal periods is from pregnancy and then after the 1 year after she gave birth. So don't be confused about the terminology, because antenatal, antepartum is during pregnancies, but postpartum is just after delivery 4 weeks. However, perinatal period is extended until the baby is 1 year old. However, mental illness may occur before pregnancies. Okay, and the right-hand side, you can see that is the minority in Thailand too. We know exactly clear that perinatal mental health affects the birth and children's developmental outcome. It starts from the low birth weight, prolonged labor, delay in initial breastfeeding because that mother cannot breastfeed, the malnutrition and delayed development of children became following. And for the long term, for mother and children relationships is not good at all, because and not only the mother and children, it may be poor in the relationship with the partner, husband, marriage. Also, we usually focus on maternal illness, maternal mental health, or children mental health. But sometimes it became that paternal anxiety and depression or mental health of the husband, of the father is not good too. Also, the family conflicts could begin from the perinatal periods. In this map, you can see that even, okay, with perinatal mental health, always outbursts in where the mental health systems is not good, usually low and middle income countries. But among the low and middle income countries, you can see that there is a various and difference of the prevalence of mental health illnesses. In this map is about perinatal depression. We can see that Tunisia and Thailand is almost the same prevalence. It's about 13%. And however, in India is higher. So what is the common mental health problem during the perinatal period in Thailand? Yes, of course, it's about perinatal depressions. Depression is very common in every single group of population. Now we are try to educate and try to focus more on the baby blue. It's 2 weeks after childbirth, because baby blue is about the emotional disturbance and such kind of symptom of depression, but not depression. It could be anything after childbirth. And the prevalence of PDD or perinatal depressions can be up to 46% in teenage pregnancy in Thailand. This is very high. And another topic which not focus more, we need to focus more in the future, is about perinatal anxiety. Again, I scope to baby blue skin, because baby blue is psycho disturbance. So it's such kind of depression, but someone's representing anxiety, also the PTSD or the fear of childbirth. We found that high to severe fear of childbirth in Thailand is around 16.8%. It's quite high prevalence. And the last thing, which is now very concerned, is about substance abuse and dependence in perinatal periods. After the kratom is such kind of regional how to say plants that misused to be substance, and the cannabis legalization in 2021 or last year. Okay, first topic is about teenage pregnancy in Thailand. We focus on this topic for long times, around 10 years, because 46% of Thai pregnant teenage found clinically depressed. So now we have special clinics for teenage pregnancies available in every district in Thailand. However, you can imagine in Eastern country and teenage pregnancy, you have special clinic, but how come it's very hard to access? So in teenage pregnancy, we also found low social support, and we have teenage pregnancy, but we have no long-term follow-up in the teenage pregnancy. So what is the gap of knowledge? We have a lack of psychoeducation, sexual education, and educational policies for the teenage, every teenage, not only the teenage who pregnant. Moreover, because Thai governments focus much on teenage pregnancy, we have sexual and contraception counseling available in every district. The same top problem, how to access. We have free contraceptions. In the right hand side, this is free for female if you age 10 to 19 years old or in teenage pregnancy to prevent teenage pregnancy. So what is the problem? Like I said again and again, stigmatization. The solution we need to do is about destigmatization for teenage pregnancy and sexual education before they turn pregnant. Like we know that the refugees is now the global burden in not only in Thailand, but yes, after you know the problem in the Myanmar, and there is many camp from the Myanmar refugees in Thailand. We found that refugees and their mental health is in crisis, especially in the perinatal period. 3% of Myanmar refugees has tried suicidal attempt. This is not good. This is a very big problem. And 25% of perinatal women has suicidal thoughts for pair suicide. This is quite a unique phenomenon for the Myanmar refugee in Thailand. Not suicide for her or just only children. They left the child, but they try to suicide with their husband. What we found is because the scrutiny of the resource in Thailand itself, not only the refugee camp, but all over Thailand. So in the camp is low social support, very low social support. And this is a huge mental health service gap. The last concerns of perinatal mental health problem in Thailand is substance and perinatal women. After the free cannabis and kratom policy, actually they say not free, it's just only medical purpose, but in practice it's free. In October 2021, no Thai government here, okay, increased rate of use in every group and significantly psychiatric consequence. You can see now in Thailand, every mental mental hospital or mental institute, 80% is about cannabis. So until now, because it's just only last year, and because of the political issues, some such kind of election next month, no, this month. So now we have not launched official report of cannabis and kratom or mitrageny. This is the scientific name of kratom effect on child perinatal women after the legalization last year. Yes, and this is like every low and middle income countries. We have limitation, not only human resource for perinatal mental health, but every dimension. So what is the solution? We have such kind of village health volunteer. The WHO called them unsung hero in the COVID-19 crisis or pandemic in 2 or 3 years ago. And yes, they are unsung hero in every healthcare crisis in Thailand. They is the big one, the key man for the community-based model of mental health care in perinatal women. They have 1.4 million Thai village volunteer. They have no income from the government, but they have some privilege for when they are sick or need to be inpatient or such kind of that. And to 1.4 million per 70 million population is quite a big proportion. So what is now about the advance for the model of care in perinatal care in by VHV? We found that there is such a pilot study of the perinatal depression model of care by VHV in some regions such as northeastern Thailand. They call Skonnakorn model. And other mental health problem in community, we can encourage them for their anxiety or substance use or domestic violence and psychological consequences by VHV to take care in the community level. Because the scrutiny of the resource, what we need, in my opinion, I don't think to add more model or to add more workload, but to embrace the perinatal mental health in usual mother health care. In the right hand side, you can see we call pink book. In Thailand, we use pink book all the time. I think more than 50 years because my mother's kept my pink book until now. It's a pink book when I was young, it's just only 2 years, but now there is 6 years, not 5, but 6 for the observation, self-observation for both mother and children about breastfeeding, about the vaccination, all things is on the pink book. So can it be possible to embrace about the such of self-observation for early sign for mental health like depression or anxiety, PHQ-2 of GAD-7, and a bit of mental health promotion like exercise or anything about relaxation therapy. So this is my reference. You can find out. And thank you for your attention. Any question?
Dr. Chonakan, we will take queries at the end. We will have an open house for discussion towards the end. Thank you so much for taking us through perinatal mental health and care services in Thailand, giving us a bird's eye picture. It was very important to kind of understand how destigmatization would really change the game in Thailand. At this point of time, I have the privilege of introducing to you two very reputed psychiatrists from Tunisia who have joined us here at Guwahati in Assam. So I will be requesting them to give their perspectives. We have the privilege of hosting Dr. Wafai Abdul Ghaffar, who is the assistant professor at the Department for Adult Psychiatry in the University Tunis Al Manar. So, and we also have a child psychiatrist in Dr. Mona Dawood, who's an assistant professor in the Department of Child Psychiatry at the same university. I'll be handing over proceedings to both of them for their comments and their expert views on perinatal mental health in Tunisia. Thank you.
Are you hearing us well? Are you hearing me well?
Yes, yes, we can hear you. We can see your screen as well.
Thank you very much. So let me introduce myself. I am Abdel Ghaffar. I am assistant professor in psychiatry in Tunisia, and I have with me my colleague Dr. Mona Dawood, which is the assistant professor in child and adolescent psychiatry. And we are very happy to be here with you in order to talk about perinatal mental services in Tunisia. So hello everyone, I'm Dr. Mona Dawood. Like my friend said, I'm a child psychiatrist. So we will be introducing mental health in the perinatal context in Tunisia. We will talk to you about existing perinatal programs in our country, the place of mental health in these programs, and then a conclusion. So as you all know, perinatal services are crucial components of public health in every country all over the world. In Tunisia, those services have made huge steps through history. We'll say some words about history. This is about perinatal programs in general. Specifically, mental health has been introduced progressively into recent perinatal programs in Tunisia. It doesn't move. The slide doesn't move. So
your slides are advancing. There's no issue with them.
Sorry?
No, sorry, your slides are advancing. There's no issue. Please go ahead.
Okay, good. Okay, now it's moving, yes. So for those of you who maybe haven't heard of Tunisia before, because we are a small country, a very small country compared to India. So Tunisia is a country in North Africa. As you can see, it is right in the center of the Mediterranean. It has a population of 12.6 million people. Just so you have maybe an idea about the level of mental care, the infant mortality rate in this year is 10.5 per 1,000 live births. So in this map, which we sourced from the UNICEF Global Database of 2022, it compares the percentage of women aged 15 to 49 attended by any provider at least 4 times during pregnancy, and in different developing countries. As you can see, for Tunisia, it's in light green, which puts it in between 80% and 100%. So let's talk now about perinatal programs. Historically, there was 2 main periods. Since the 60s, the government tried to implement general prerequisite measures. And then after the 90s, there were the implementation of the National Perinatal Program itself. So we'll have more details about these periods. So from 1960 to 1990, which is the period just after the French colonization, there were efforts that were made about legislation. For example, there were many pro-feminine policies that were introduced. For example, there were the ban of polygamy in Tunisia. Women have the right to ask for divorce. All marriage contracts are civil contracts. There was also the implementation of mandatory prenuptial medical consultation. This consultation ends at screening for genetic diseases and advice on the genetic risk related to first cousin marriages. It is also an opportunity to make sexual education. Also, there were many efforts in the fields of planned parenthood, so women have the right to plan their parenthood. And there is free contraception available for all married women and all women in general in local communities, the healthcares. Women also have the right for abortion in the first 12 weeks of pregnancy. Finally, there were efforts that were made in order to promote primary care services, and especially in every service nearly there is a mother and child unit dedicated only for mother and children. As we were saying, in the 90s, the perinatal program's main objective was to reduce maternal and perinatal mortality. In order to do that, there was professional training for healthcare givers. Perinatal services were installed in nearly all healthcare centers and for free. And there was enhanced coordination between primary care centers and reference healthcare centers. So these are some of the axes of this program. There was community education through mass education, posters, media on the importance of health, perinatal health. There is a mandatory vaccination, which is mandatory and free for all children from 0 to 18 months. And there is a consensus that was made about the follow-up of an expectant mother. Midwives, there was an empowerment of midwives which are implicated in this program in all primary care and healthcare services. There are some explorations that are necessary. There was prevention of anemia, etc. So the key accomplishment of the 90s, of all of the work that was done in the 90s, was primarily the reduction of the infant mortality rate. So as you can see, already in 1994, we had a rate that was comparable to most developed countries and a decrease in the birth rate. But there are still regional discrepancies. In all healthcare indicators, all economical indicators, there is always better conditions in the coastal regions compared to inner regions in Tunisia. So after this phase, there were the second phase of the perinatal program beginning in the year 2000 until 2015. And here the objective was to enhance the quality of the services and ensure regional quality. During the second phase of the perinatal program, there were some additions, like including at least 3 ultrasounds for every pregnant woman during her pregnancy, and all cases of maternal death were investigated. So let's focus now on perinatal mental health itself. We must first say some words about the current situation. For example, in Tunisia, like nearly all developing countries, mental disorders in children are frequent. There is some delay in the diagnosis. There are sometimes problems in access to mental health care. For example, there are nearly 50 child psychiatrists in all Tunisia, with regional discrepancies. So there is a lack of specialists in the inner regions. It is estimated that 20% of children are vulnerable or have disabilities, or their families and mothers are in need of support. Unfortunately, mental health was not integrated in previous national health programs in history in the programs like we will see later. There is no national data on peripartum mental illnesses in mothers, for example, or depression. These are still important again.